I'm one of the new consultants at RBH. I mainly do obstetrics and my interest is fetal medicine, so I'm going to be talking to you about obstetric scanning and what the sort of expectations and requirements are for you at this stage of your training. I'm just going to try and share my presentation. Okay, can everybody see that?
Yes, we can. Thank you.
Okay, cool.
Can you make it slightly bigger though, Shivani?
Yeah.
It feels sweet. Yeah, thank you.
Is that better?
Yes.
Yes.
Okay,
Yeah.
cool. Okay, so scanning is a relatively new component of the curriculum. It was only introduced about 10 years ago, which is relatively recent if you think of the fact that trainees have been getting assessed in cesareans and instrumentals since, the start of training as it exists now. But it is a really important skill if you're going to be working in obstetrics. We have sonographers, obviously, but they normally just work Monday to Friday, 9 to 5, and there are many times when you'll need to do scans outside of those working hours. For example, confirming presentations before cesarean sections, or if patients come in labour with a suspected malpresentation, somebody comes in with bleeding and you need to rule out a low-lying placenta, confirming an intrauterine death. And the new ATSM curriculum for labour ward even includes scanning for fetal position. So it is something which, even if you don't have an interest in scanning, everybody is going to be involved in it in the future. By the end of ST3, you will be expected to complete the transabdominal ultrasound examination in the second and third trimester module. And that involves being able to competently perform ultrasound assessment of the fetal presentation, liquor volume and placental location. And under supervision, you will also need to do some biometry assessments as well. So you'll need summative assessments for the lie presentation, liquor and placenta, and formative assessment for the measurement of the HC abdominal circumference and femur length. And the training matrix also says you should attend a basic ultrasound course by the end of ST2. So I'm sure lots of you have had experience of using the ultrasound machine so far. Obviously, there are different types of probes. The one on the left-hand side is the transvaginal probe, which is mainly used in early pregnancy or other types of gynae scans. For scanning in later pregnancy in the second and third trimester, you would mainly use the abdominal probes. There are different types of probes, both 2D probes and 3D probes on the right-hand side of the screen. And normally, the best one to use is the curvilinear probe. They all have different frequencies, they show you slightly different things, but for the purposes of what you need to get signed off, the curvilinear probe is the best one to use normally. Different machines are set up slightly differently. Typically in the labour ward, there'll be quite a basic machine because the most expensive machines tend to go to the scan department. But even with an old machine, you can normally see most of what you need to see. And these are the main buttons that you will need to use. So the pulse wave will show you, will let you listen to the baby's heartbeat. The colour button is to look at flow. So if you want to check the blood flowing through the baby's heart or in the baby's cord, you can press the CF button. The measurement button will enable you to take biometry measurements, so measure the baby's head and the tummy and the leg. It's the roller ball button in the middle will let you go back. A lot of obviously babies are moving around all the time, and sometimes you'll see the perfect image and then it will just flash by, so you can freeze and go back to it. And then on the right-hand side of this particular machine, you can change the depth of the ultrasound setting and zoom in, use the zoom button, which can be very useful depending on the gestation or if you have patients with very high BMIs. So when you're preparing a patient for scanning, you need to have them in this kind of semi-recumbent position, so lying at more or less a 45-degree angle. And you need to be fairly close to them as well in order to scan them comfortably. Otherwise, you're going to put quite a lot of strain on your arm. A lot of patients come along with a full bladder. They have this kind of conception that they need to have a full bladder before having a scan, which can be useful in early pregnancy, but it's not necessary. In the second and third trimester, the baby's big enough to be seen clearly without having a full bladder. And actually having a full bladder can be a bit of an obstruction to scanning. It can be quite uncomfortable for the patient. And it can also sometimes push the baby into a funny position. So if the patient's bladder is full, I normally tell them to empty it before starting. You need to obviously make yourself comfortable, adjust the height of the bed, make sure that you're close enough to the patient, and make sure that the machine is ready to use and the probes are clean. Obviously, it should be the responsibility of whoever has last used the machine to clean it, but sometimes that doesn't happen in an emergency. So just make sure the machine's ready to use. And normally, for later pregnancy scans, I would recommend putting the ultrasound gel over the patient's abdomen rather than on the ultrasound probe itself, because it just spreads out a bit more easily. Then you'll need to check the orientation of the probe. So all ultrasound probes will have an orientation marker. It might look a little bit different depending on the type of probe that you're using. And that corresponds to the orientation marker on the scan on the screen. So you can see in this example, the orientation marker is on the left-hand side of the screen. And you can change it actually, but normally it's on the left-hand side. And that means that when you're scanning somebody, whatever is closest to the orientation marker on the probe will show up on the left-hand side of the screen. And that's really important, especially when you're trying to work out fetal position with scanning. And it doesn't actually matter which way around you do it, as long as you know which way you're doing it. So my preference is to have the orientation marker towards the left-hand side of the patient. And then the orientation, that's showing me that whatever is on the left-hand side of the patient will appear on the left-hand side of the screen. Then if I want to scan in a longitudinal dimension, I turn the orientation marker towards the patient's head. So whatever is closest to the patient's head will then be on the left-hand side of the screen. But it doesn't actually matter as long as you know what you're doing. So some people choose to do it the other way, but it's important that you don't confuse yourself, basically. In terms of the screen is going to show you a 2D image of a 4D structure. So you need to use a little bit of imagination with it. Whatever is at the top of the screen, obviously, is going to be closest to the ultrasound probe. And whatever is at the bottom of the screen is going to be further away. So you need to determine the lie of the baby and the fetal presentation using the scan. And these terms are often used interchangeably, but they do mean something different. So the lie is the relationship between the longitudinal axis of the fetus and the mother. So lies can either be longitudinal lie, so that's when the baby is kind of up and down in relation to the maternal abdomen. So both cephalic and breech presentations are typically longitudinal. Or the baby can be in a transverse lie, so lying across the way, or lying obliquely, where it's kind of diagonal. The presentation refers to the part of the baby that's entering the maternal pelvis. So what you can see above the mother's pubic symphysis when you're scanning. So that can either be cephalic, if the head is there, breech, or you can have other more unusual presentations, for example, a brow presentation or a face presentation. And the fetal position is the position of the presenting part. So cephalic babies can either be, we normally describe it in relation to where the baby's occiput is. They can either be occiput anterior or posterior. If it's a breech presentation, then we describe it in relation to where the baby's sacrum is. With face presentations, we describe it where the baby's chin is. So it can either be mentum anterior omentum posterior. So when you're scanning to determine the fetal lie or presentation, you obviously need to check your probe orientation and just develop a system for doing it. Normally, we start scanning with the probe in a horizontal plane just above the pubic symphysis, because you want to work out what's the presenting part, what am I seeing under the pubic symphysis. And then you can slide the probe over the patient's abdomen to try and work out what's the lie, how is the baby lying in the mum's abdomen. And particularly in transverse and oblique lies, you'll often need to slide the transducer right over to the lateral edges of the abdomen to see where the baby's head is. And then if you rotate your probe 90 degrees so that you're in the longitudinal section, you can confirm it, basically, particularly at earlier gestations. And you just have to be very mindful of where your orientation marker is, because you can end up confusing yourself sometimes, especially at earlier gestations. Cephalic and breech babies can look the same depending on which way around your orientation marker is. So then we need to assess the Leica volume, the water around the baby. Normally, actually, most people just use a kind of subjective assessment and just eyeball the fluid around the baby and make a judgment about whether it's a normal amount or too little or too much. But for the purposes of your assessments, you'll need to measure a maximum vertical pool depth, or deepest vertical pocket. And that should be between 2 and 8 centimeters. So when you're scanning over the mum's abdomen, looking at the fluid around the baby, you just need to spot whichever pool looks the deepest, freeze the screen and take a measurement of it. The logbook also suggests that you should measure the amniotic fluid index as well. It's not something that people often do, but basically it involves measuring the deepest vertical pocket in each of the 4 quadrants of the uterus. So if you imagine the womb kind of divided into the 4, normally with the umbilicus in the middle, then just scanning over each of the quadrants and taking the deepest measurement and adding them all up, basically. Oligohydramnios, or reduced Leica, is when the DVP is less than 2 centimeters, and you might see that if the patient's ruptured her membranes, if this is a patient with placental insufficiency or IUGR, or if the baby's kidneys aren't working and the baby's not producing as much urine as it should. Polyhydramnios is if it's more than 8 centimeters, and that's typically associated with things like diabetes or congenital infections in the baby, or if there is a structural defect and the baby has difficulty with swallowing. So yeah, this is pretty much what I said. Most people just use a subjective assessment, but you will need to be signed off for taking the measurements as well. Everything that appears black on the screen is water. So the baby should be surrounded by the black fluid, and other things which will look black on the scan are the stomach, because the baby's swallowing, it's Leica. The bladder will be black as well. So that's really what you're looking for. With oligohydramnios, if there's reduced Leica around the baby, it's often a bit more difficult to see the fetal parts clearly. And with polyhydramnios, if there's lots of extra fluid, the abdomen's often quite tense. And you might need to change the depth on the ultrasound machine, because the water sort of pushes the baby away from the probe. It's often difficult to get good images. And you need to make sure when you're measuring the deepest vertical pool that it's a free pool. It doesn't have any fetal parts in it or any cord in it. And sometimes the cord isn't that clear to see, so it might be useful to put the color flow on just to make sure that there isn't any cord floating in the pocket that you're planning to measure. So this is a really terrible drawing, but basically it's just to demonstrate that you need to be quite careful about how you hold the probe. So your probe should be perpendicular to the mum's abdomen, because that will give you a different deepest vertical pocket compared to if you hold your probe at an angle. So you need to be quite strict with yourself in terms of how you're holding the probe in order to make sure that you're getting an accurate measurement and not underestimating or overestimating how much fluid there is around the baby. And then we need to assess the placental position. So the placenta typically looks like kind of bright white mass, and it's on the wall of the uterus. And ultimately what you want to know is the placenta low-lying? Is it going to cause an obstruction to delivery, cause bleeding? So the best way to work that out is to have the probe in the longitudinal position and identify where the edge of the placenta is in relation to the lower segment of the uterus. It's always easier to see structures which are on the front wall of the womb. So with posterior placentas, it will be behind the baby. The images might not be as good, and you'll often have to adjust the depth in order to see it clearly. It's often very difficult to visualize the cervix on a transabdominal scan. So ultimately, if it looks like the placenta is low-lying, if it's above the maternal pubic symphysis, if you suspect it is, you would, in real life terms, need to do a transvaginal scan to see if it's overlying the cervix or close to the cervix and would be classified as a placenta previa. But you can look at where it is in relation to the presenting part. So if you can see an anterior placenta, but you can see the baby's head below that, then it's very unlikely to be a low-lying placenta. And often low-lying placentas are associated with malpresentations as well. So, if there's a placenta over the cervix, then it's a bit more likely that the baby will be breech or might be in a transverse lie because there's something, in the pelvis blocking the baby's head from going in. And again, you just need to remember to scan laterally as well to either side, because the lowest edge of the placenta might not necessarily be in the midline of the maternal abdomen. And these pictures just demonstrate what you're looking for. So the first one is a transvaginal scan, which is outside the remit of what you would be expected to do, but you can see that shows clearly that the placenta is lying on top of the cervix. The middle picture, well, the final two pictures just show what an anterior and posterior placenta look like. So it's separate to the baby, it's on the wall of the womb. It's much easier to see the anterior one compared to the posterior placenta. So you also need to do some basic biometry measurements. It's not something that you're expected to be able to do independently at this stage, but you should know what you're looking for. So the three measurements that we take are measurement of the baby's head, the baby's abdomen, and the baby's femur. The head circumference, what you're looking to see is a rugby ball shape, and you should see skull all of the way around. So bone always appears bright white on the ultrasound scan because it contains calcium. And that's how we differentiate the head from the abdomen, really. When we're taking a measurement of the abdominal circumference, we should see one of the ribs, but obviously the rib wouldn't go all the way around the abdomen, whereas you should ideally see bright white bone all the way around the head. What you want to see is a clear midline structure, and both sides should be symmetrical. At the front of the baby's brain, you'll see a little black box, which we call the CSP, cavum septum pellucidum. And then towards the back of the baby's brain, we've got the choroid plexus, which is a white mass which produces fluid. So there will be a ventricle beside it. And then we've got the thalami either side of the midline. So these are the ideal structures that you want to see when you're taking a measurement of the HC in order to confidently say this is an accurate measurement of the head. So you can see this is a nice kind of rugby ball shape. We've got a midline here, both sides look the same. We've got the CSP here, this black box. The thalami are over here. This is the choroid plexus, and it's producing fluid, which are going into the lateral ventricles of the brain. It's always easier to see the one, ironically, that's further away from the probe compared to this one over here. So this would be a good one to measure the head circumference on. Other structures in the brain which you can see, which might indicate that you're not in the correct angle, would be if you see the cerebellum. So the cerebellum is this dumbbell structure, and that's at the back of the brain. So this I mean, if you want to measure the cerebellum, this is a good image, but that's obviously not what we're trying to achieve. If you see this, then you want to, it means that you're too low on the posterior side of the brain, and you need to adjust your ultrasound probe upwards a bit in order to get the ideal HC image. If you should always see the black box. If you don't see the CSP, you're probably not in the right plane at the front of the baby's brain, and you might need to adjust your probe over there. When we measure the abdominal circumference, we want it to be as circular as possible. A lot of the time, I mean, the abdomen is probably the image which is most kind of subject to variation. For example, if the baby takes a big gulp of fluid, its abdomen will expand. If it's breathing in and out, that can make a difference to how big the abdomen is. And a lot of the time, it won't necessarily be a perfect circle, but you want it to be as close to being a perfect circle as possible. And the structures that you want to see clearly are at least one rib. You should see this black stomach over here, which would be on the same side as the baby's heart. There's the umbilical vein inside the abdomen, and we should see the spinous processes. And if we want to measure the AC, that's going all the way around. And you can draw circles using the ultrasound machine to measure around the AC, or some places measure across the abdomen, so from the front to the back, and then a transverse abdominal diameter across here. So a typical thing when you're scanning is that you might often end up seeing the umbilical vein, the stomach, but you can't get one complete rib. You're getting these different parts of the rib, and that means that you're probably hitting the baby a bit obliquely, and you need to twist your probe to try and get a full rib in. Obviously, we are very much subject to the position of the baby when we're doing scans, and we can't change the position of the baby. So all we can do is change what's within our control, which involves changing the probe. If you sit with the sonographers, you might see them moving the patient around, getting her to lie on one side, or sometimes even getting up and going for a walk and scanning her again, because sometimes the baby's position will change. These are the baby's kidneys. So the kidneys are just below what you want to see. And if you see these kidneys, it means that you need to move the ultrasound probe up a little bit on the baby's abdomen because you've gone a little bit lower. Ideally, what we want to see is the bit just underneath the rib cage. This is the baby's heart. So if you see this, then you want to go a bit further down. And sometimes you can end up getting a little bit of the baby's lung in. You can see in this transverse section that the lung is a bit brighter compared to the abdomen. So if you get a rim of bright tissue, then you're probably a little bit higher. You're probably kind of over here, and you need to move your probe down a little bit so you get over here. And the way that you move the probe will depend on the position of the baby as well. A cephalic baby is going to be upside down, essentially. You know, the baby's head is closer to the mum's feet. So if you're wanting to move the probe up on the baby, it means moving the probe down on the maternal abdomen. And then finally, we need to measure the femur length. So you need to be quite systematic when you're measuring the baby's femur. There are 12 long bones in the body, 2 humeruses, 2 femurs, radius ulna, tibia and fibula. So if you're not systematic, you can end up measuring any of them, and they all look the same. You can't tell by looking at them which one is the femur. So to ensure you've got the femur, I would recommend looking for the baby's bladder. So looking at the baby's abdomen and then going down till you see the baby's bladder, and then twisting your probe from there to get the femur. Particularly with measuring bones, it's a good idea to try and optimize the image as much as you can. So you can either change the depth, or you can put the zoom box on, which is what's been done here to magnify the leg. And you can also change the gain on the machine, or some machines have a dynamic contrast button, and that just highlights what the bone is, because ideally You want to have very clear lines when you're measuring the bone. This image hasn't been adjusted that much, so the bone doesn't really look that bright. It's not as easy to see, whereas whoever's done this scan has changed the gain, so it's a lot clearer to see the bone and you can get more accurate measurements, and you want to make sure you can see the edges of the bone clearly. So yeah, if you go down from your abdominal circumference, move the probe down on the baby's abdomen, then you'll get to the bladder, and you can tell it's the if you're not sure it's the bladder, you could put the color flow on and you can see umbilical cord on either side. And then you can you know that the femur will be close to the bladder. So if you gently turn your probe, you should be able to see it from there. And this is a picture of the humerus, and they look the same. So you can't just put the probe on and find a long bone. You do need to be quite systematic about making sure that you have the right one, basically, because although they look the same, they won't measure the same. So in summary, as with any practical skill, it really just involves lots of practice, and you're very welcome to attend fetal medicine departments or sit with the sonographers. But there's often lots of opportunities to scan in other environments as well. People who are coming for ECVs or, if they're having scans to confirm the presentation before elective sections, those are very good opportunities to practice scanning. There are lots of useful resources online as well. If you sign up for the NHS e-learning for health modules, they've got interpretation of radiological images module and a FAST module, and it's kind of like an online e-learning package which just goes through what you're looking for with doing ultrasound scans. The International Society of Ultrasound and Obstetrics and Gynecology offers free membership for trainees, and the Fetal Medicine Foundation also has a lot of useful information. And there are useful strategy modules as well, both about technical things, which I haven't really discussed much today, about the thermal index and sort of physics side of things, but also about what you're looking for when you're scanning. Okay, any questions at all?